to go ahead and just
Okay, perfect. Thank you so much. Thank you for that introduction. Thank you, everybody, for joining today for this educational presentation. We are going to be talking about Parkinson's and more specifically, a complication of treatment that can occur from Parkinson's, and that is impulse control disorders. A special thank you to Allison and Cognitive Care Solutions for providing this forum for educating patients. They are very, very helpful. I refer a lot of patients their way. So if you're struggling with any mood issues, depression, anxiety, family interpersonal issues, then they are an extremely helpful resource. Okay.
thank you.
A little bit about myself. I know Allison gave a fantastic introduction, but I am a PA. I'm practicing in Irvine. We have a very special little team. We have a movement disorder specialist, Dr. Sandeep Thakar, and two other PAs, Catherine King and Cheryl Kin. And we are a mighty team. Our day in and day out focus is managing Parkinson's and other movement disorders. Because Parkinson's is the most common movement disorder, I would say about 80% of my patient population has Parkinson's. And a fun fact about myself is before I actually became a healthcare provider, I was already in this space and I was already interacting with this patient population. My very first job before in medicine actually was as a medical assistant. So I was the support staff, I was answering phone calls, and just by fate and happenstance, I happened to be paired with a movement disorder specialist. So that's how I kind of fell in love with the field. I fell in love with patients. I fell in love with, treating not only the patient, but the whole support system as a whole. And I knew that this is where what I was destined to do. So I went to PA school, and I've been working in the Parkinson's space ever since. So anyway, I am excited to impart some of my knowledge. And please, again, Allison mentioned, but if you have any questions, feel free to put them in the chat. And then at the end of the presentation, I'm happy to answer some of those questions. All right, so a little bit of background. Before we start talking about Parkinson's, we have to have a discussion about dopamine. You may hear a million things about dopamine this, dopamine that, but what is dopamine? So dopamine is a feel-good chemical that your brain releases. Colloquially, you may hear of people saying that they're dopamine junkies, right? Somebody who craves those adrenaline rushes, or somebody gets a hit of dopamine, meaning they do something that makes them feel really good. So dopamine is a chemical in the brain that helps regulate a lot of different things. It's not only a feel-good or pleasure chemical, it's also implicated in movement, motivation, memory, sleep, etc. There are many functions of dopamine. Because of that, Parkinson's can affect many different body systems, which we'll talk about a little bit later. And this is kind of an oversimplification, so I will admit that. But just to kind of illustrate the point, when you have low dopamine levels, theoretically, you as a person would be very tired, unmotivated, maybe depressed. And then on the flip side, if you have super high dopamine levels, you may feel anxious, jittery, agitated, or even manic. And so obviously the goal is to maintain balanced dopamine levels. And someone who has balanced dopamine levels is going to feel happy, satisfied. They may get a little hit of dopamine from doing an exercise or something else, but once those dopamine levels level back out, they go right back to feeling how they should, which is just satisfied and happy. So again, a dopamine boost is a pleasurable activity. It will give you that boost. So for example, getting a really good workout in, you may hear about releasing endorphins. And so one of those endorphins being dopamine. So when you get, you go on a run or you hit the gym, you're going to get a little boost of dopamine. Similarly, eating a really good meal, petting a cute dog, seeing a cute baby. These are all things that will deliver a little increase in dopamine. Now, anything that is good, you can unfortunately have too much of. And there are things that provide a disproportionate boost in dopamine, basically way higher than you would get from any normal activity. So the most classic example is drugs, right? If somebody is using heroin, they're going to feel really, really good. And people get unfortunately addicted to that feeling. They're constantly chasing that high or that feel good too much, and that can become destructive. So, for example, shopping addiction, gambling addiction, sex addiction, which can not only be engaging in sexual activity, but engaging in pornographic material, and then, of course, drugs and alcohol. Okay, so as you can imagine, and I kind of just touched on, your dopamine can become dysregulated, and that can actually result in a number of disease states. So, for example, low dopamine states can be associated with depression, which makes sense. ADHD, interestingly, is actually a disease state implicated in low dopamine levels. It may seem like it's high because people are hyperactive, but actually that shifting of attention and constantly seeking, external stimuli to kind of fulfill that need. We see that with ADHD. Additionally, restless leg syndrome is a low dopamine state and it is treated with dopamine agonists. And then, of course, Parkinson's, which is the focus of today's presentation. And you can see here on the right side at the top, you see a normal neuron that is releasing a good, healthy amount of dopamine. And then on the bottom, you see a Parkinson's affected neuron where there is lower release of dopamine, which can lead to movement and other issues. On the flip side, which is not as much a focus of today's presentation, but there are disease states that are associated with high levels of dopamine. So, for example, the manic phase of bipolar disorder and also schizophrenia. So, people, they're just naturally or genetically inclined to develop hallucinations and delusions, and that is associated with a high dopamine state. Okay. So, we're going to talk about Parkinson's, which is the quote unquote dopamine disease. And what Parkinson's is, it's a neurodegenerative or progressive loss of dopamine producing cells in the brain. And an interesting fact that a lot of my patients are surprised to hear are that by the time you develop motor symptoms, meaning tremor, stiffness, or slowness, there has already been a loss of about 60 to 80% of those dopamine producing cells. Um, Oftentimes, hindsight's 2020. I'm asking questions about, have you been having constipation? And they're like, oh yeah, I have been having that for 10 years now. Or I've started losing my sense of smell 5 years ago. Or yeah, I do act out of my sleep, right? There are these little hints that start manifesting many, many years before diagnosis. And those hints are where that loss of dopamine is already starting. And then by the time you develop motor symptoms, already so much dopamine has unfortunately been lost. It is the fastest growing neurodegenerative disease worldwide. As far as what is the number one most common by sheer numbers, Alzheimer's is number one. But if you look at the rate of increase, so how many new diagnoses per year, how fast is it growing? Parkinson's is definitely number one there. So because dopamine facilitates movement, when the dopamine levels are low, which we see with Parkinson's, movement becomes more challenging. So if you look at the graphic on the left side, you kind of see this stooped posture, decreased facial expression, decreased arm swing, shuffling gait, and these are physical features that we see with Parkinson's. And as you can imagine, the way that we treat this disorder is by trying to increase or somehow modulate the dopamine levels in the brain. So this is one of my favorite graphics when it comes to Parkinson's. I see it at pretty much every single Parkinson's conference I go to, which is a lot, and is the Parkinson's iceberg. So the idea is at the top of the surface, so what you see and what also other people see are the motor symptoms. So if someone sees your hand shaking, obviously that is externally visible, but not everyone with Parkinson's has tremor. So you may just be someone who's stiff and slow. And again, those are external features that other people can visualize. Now, what lies underneath the surface, and you can see there's a lot. And unfortunately, these non-motor symptoms or other features that are not the physical manifestations of Parkinson's oftentimes can be way more bothersome, way more disabling, and way more disruptive to someone's quality of life. So you would think that myself, as somebody who treats Parkinson's, I'm talking all day about tremor. And that's not necessarily the case. In fact, I would say the majority of my visits are spent talking about everything else under the iceberg. So constipation, memory issues, anxiety, depression, blood pressure control issues, sleep issues. I could go on and on. And the reason for this is because dopamine is important not only for movement, I touched on this earlier, but there are implications of dopamine in memory, sleep, mood, etc. But the other thing is that Parkinson's is associated not only with a low dopamine state, but there are other neurotransmitters that are affected as well. So, for example, Parkinson's can be associated with low serotonin state, low norepinephrine state, and those are two neurotransmitters involved in mood. Additionally, it's associated with low acetylcholine, which is a neurotransmitter that is impacted with memory. And then lastly, disrupted melatonin. So that, explains why someone may feel really fatigued during the day and then they're awake all night or they can't get into a deep rested state of sleep. So the way that we treat, again, my favorite way to kind of explain this is using an analogy. So, for example, if you go to your primary care provider and you get your annual labs done, and the labs come back and show that you have low vitamin D, then what is the next logical step? It would be either to take a vitamin D supplement or maybe get some natural vitamin D. Similarly, if you have low iron, low hemoglobin, you're going to eat more iron-rich foods or take an iron supplement, right? And then if you have low thyroid hormone, then you probably will be prescribed levothyroxine, which is a way to replenish that hormone. So similarly, with Parkinson's, if you have low dopamine, we want to increase dopamine. And this sounds super simple, but there's actually many different ways to do this. We are in a very blessed time where we have access to so many different medications, so many different treatment options. And at least 5 of all the different classes of meds modulate dopamine in some way. So the gold standard treatment is carbidopa levodopa, which essentially is a dopamine supplement. When you take it, your body metabolizes it, it crosses your blood-brain barrier and literally becomes dopamine. So it's our way of increasing those dopamine levels. But there's other medicines that block enzymes that prevent the breakdown of dopamine. There's other medicines that bind to dopamine receptors, and those are called dopamine agonists, which we'll talk about in a little bit. And so we have many different options now, and most of them work on modulating dopamine. Now, a key point here is I do have a number of patients who are apprehensive about taking medication or about potential side effects, and that's totally fair. I completely understand. But we also have to think about a few things, which is how clinical trials are designed and how these side effect lists are created. So when you pick up a medication and you have 3 pages of potential side effects, that's anxiety provoking. And again, I completely understand, but I try to emphasize that not all of those side effects are directly tied to the medication. And also not all those side effects are necessarily going to happen to you. I try to emphasize the main side effects that are likely to happen or, I see a lot on a common basis. And then there's all the ones that, I would say, it's theoretically possible, but I really don't see it that much. The way clinical trials are designed are, they enroll a bunch of patients, and for these drugs, Parkinson's patients, and they follow these patients over time, and anything that they experience during that time period goes on the list, regardless if it's from the medication or not. And that's because there's no way for them to say 100% certainty that it's not from the drug. So, for example, what do Parkinson's patients experience? A lot of constipation, depression, balance issues. So if those and you'll see this, every Parkinson's medicine has all of these on the side effect label. Sometimes it may be related, but also sometimes it may not be. So keep that in mind. Another point I wanted to make is that the $1 million question is about disease modifying drugs or drugs that may delay disease progression. And the way that things are now, the current state that we're in, we do not, unfortunately, have medications that have been shown in clinical trials to delay disease progression. That being said, it's not a moot point. It's not that it's not worth taking these medications. And it's also why I emphasize exercise so much, because exercise has been shown to delay disease progression. So honestly, sometimes I feel like my job is being an exercise motivational speaker, but that's because it really is so important. Now, my point about it's still worth it to take the medications. The reason I say that is because we have shown through studies that poor medical management can actually be disease modifying in a negative way. And what I mean by that is if you have someone who probably should be on medication, either maybe they're really stiff and slow, maybe they're really high fall risk, and they sustain health complications from that, for example, a hip fracture or a hospitalization from pneumonia, then those health events can actually make the disease progress faster, which is very unfortunate, but I have seen it. So if you think about it, anything that's super stressful to the system, a long surgery, anesthesia, a big infection, I could go on and on. These things actually can make the disease progress faster. And therefore, I can still make the argument that it's important to optimally medically manage your symptoms, talk to your healthcare provider about options that you have. And yes, all meds have side effects, but many people, especially if you start low and kind of titrate up, many people were able to get to a level of tolerance and simultaneously benefit. Okay, so not all dopamine is the same. I said dopamine probably 1 million times already in this presentation, but not all of it is the same. So for the purposes of this talk, there are 5 dopamine receptors. They're very simply and easily titled D1, D2, D3, D4, D5. And different medications target different dopamine receptors, and that also will play into their side effect profile. So, number 1 is dopamine, which again, carbidopa levodopa, when you take it, it does convert into dopamine. So the main receptors that it targets are D5 and D1 receptors. And those are really in my opinion, the gold standard, what we really want to target with medication therapy. Now, as far as other medications, so there's a medication class called dopamine agonists. Examples of these meds would be ropinirole or Requip is the brand name, pramipexole or Mirapex, and rotigotine or the Nupro patch. And you can see here from the receptor activity that these medications target more so D2 and D3 receptors. So as far as what does that mean or what's the implication of that, D2 receptors specifically have implications in hallucinations. So if you overstimulate D2 receptors, you likely will develop hallucinations and delusions, which that can be, I can have a whole talk about that. We can go into that on a different day, but specifically, the way that I think about it is that schizophrenia medications, so there are people, again, naturally, genetically or whatnot, they have hallucinations and delusions. The medications that they take to treat their symptoms block D2 receptors. Okay. Now, D3 has implications in reward and motivation. If you overstimulate D3 receptors, it's like pushing the gas pedal down on that motivation reward system loop, and it can really drive impulsivity and addiction. So classically, dopamine agonists, again, ropinirole, pramipexole, and the Nupro patch, as a group, were notorious for causing these side effects. Now, I will say, I want to make a point here, which is I know dopamine agonists, just based on, the information that I'm saying, can seem really scary. Or if you personally are taking one, you may be like, oh my gosh, why did my doctor or healthcare provider prescribe this to me? There is absolutely still a utility, and I don't think that any medications inherently are good or bad. Again, we are in a blessed state where we have access to many options, and the more options that we have is ultimately better for patients. So I still utilize these medications, but we just keep in mind that these side effects are a possibility. I try to counsel patients before we start them about looking out for things like this. But I still use them. And like I said, they can be really helpful for motor symptoms. They can be really helpful for people who also have restless leg syndrome. That's kind of the dinger right there. You can kind of kill two birds with one stone. And so again, they are not inherently bad, but just for educational purposes, it's important to know what to look out for. Now, there's kind of a new group or the new kids on the block of other dopamine agonists that actually do not target the same receptors that the classic ones do. So, interestingly, apomorphine, it's an old dopamine agonist, but lately it has been utilized kind of in a new way. It's a dopamine agonist that mostly targets D1 and D5. So, chemically, it is much more similar to levodopa and therefore has a much lower risk of hallucinations and impulsivity. It's still there. Nothing is zero risk, but I would say comparatively a much lower risk. So Apokin was an as-needed injectable option that was utilized, and then Onapgo is the new version. It's a continuous pump over a 16-hour period, and that's been definitely fun to utilize and get to know since it's so new. I'm still kind of learning that. But and there's a new one called tavapadon. It hasn't yet been FDA approved, but it is very, very close. It's pretty much slated to be FDA approved probably this year, so in 2026. And that one also is a selective dopamine agonist targeting D1 and D5 receptors. So I'm really excited about that. Of course, things, are different. Like sometimes clinical trial and real life are different, but so far, based on the data, it looks super promising. And so once that gets approved, I'm absolutely, excited to add that to my toolbox. Okay, so a little bit of a history lesson, talking about levodopa and the tendency of the old way of practice. So when levodopa was first approved, it was in the 1960s. It truly was a miracle drug. And when I say that, I mean we had patients who had significant motor issues. They had very limited treatment options. And basically over time, like from the time they're diagnosed, we just see them decline and decline. And it was very hard. There's limited options, and these patients didn't do very well. And so when levodopa hit the market, it really was like a miracle. We saw significant improvement in tremor, stiffness, slowness, not only that, in non-motor symptoms. And because of that, and I don't blame anyone for this, naturally, there was a tendency to go up and up on the dose. So over time, as the disease would progress, you'd start out with one tablet 3 times a day, and then, maybe that wasn't enough. 2 years down the line, then you're on 2 tablets 3 times a day, and so on and so forth. And so people ended up on very high doses of levodopa. And again, this was before we kind of knew the long-term consequences of utilizing the medication in that way. And so what inevitably happened was people were developing dyskinesia, which a lot of people kind of confuse the difference between dyskinesia and tremor, or dyskinesia and dystonia. Dyskinesia is a direct side effect of levodopa. It's from taking too much levodopa. And what it is the involuntary wiggling, rocking movements. Most famously is obviously Michael J. Fox. If you've seen a video of him, he's sitting in a chair, he can barely sit still. He's rocking and writhing around. And that's not from Parkinson's, actually. He doesn't look that way because of Parkinson's. He looks that way because of levodopa. He takes a lot. He does. He takes a lot. And people were getting dyskinesia when the medicine was peaking. And then as the medicine is wearing off, they're developing off periods, which is where they wear off of their medication and they're getting, periods of stiffness and slowness. And then they're waiting to take their next pill so that they can become on again. And so this phenomenon is called motor fluctuations. And so once we saw those complications of utilizing levodopa, then the new propensity became to hold off on starting it as long as possible. Because the idea is once the train has left the station, supposedly, so once you've started levodopa, it's going to be an inevitable increase and escalation of the dose, and then you're going to have motor fluctuations. So that was the whole idea. And especially for young onset patients, I have some patients who are diagnosed in their 30s, 40s, right? If I'm thinking about their long term, they have many decades ahead where they're going to be, theoretically on medication or levodopa. And so the idea was let's hold off on starting and instead use other options. And so then the new kind of wave was to utilize dopamine agonists, which, as we talked about, target D2 and D3 receptors more so. It does have lower risk of dyskinesia and motor fluctuations. But kind of the same idea happened, which was people were taking dopamine agonists, they were going up and up on the dose. And then the downside came, which was people were developing impulse control disorders. So, what are impulse control disorders? So these are a direct side effect of taking dopaminergic medication, but most classically dopamine agonists because of that D2, D3 receptor activity. And it is a strong, irresistible urge to partake in any behavior. Now, this can be good things and it can also be bad things. So the bad things, like the vices, would be shopping. I've had patients, they tell me that they spent $800 on Amazon or on Temu, and they're not someone who typically does that. They got in this zone and they literally could not stop themselves. Gambling, I've had patients take up online poker or they love going to the casino, and it's different than, just going for fun or just going every once in a while. It becomes literally this habitual type of behavior that they can't stop. And unfortunately, I've had many people gamble their retirement, their life savings away, and puts them in a really, really bad financial position. Eating, so compulsive eating, constantly snacking, eating candy, chocolate, ice cream, and obviously that's not good for your health, but also it can be, destructive to their overall success because I have this conversation all the time with my patients, but the food and, the drinks and everything you put into your body are your fuel. And so then they would be struggling with, more motor symptoms or more mood issues or whatnot. Sex, this is a big one. People develop along with ICDs, they develop hypersexual behavior. So that could either be partaking in sexual activity, either with your partner or even stepping outside of your relationship or your marriage and having an affair, which obviously can be devastating, or consuming pornographic material. And I have had patients kind of when they're in this impulsive state, they kind of take up a porn addiction, which is super unfortunate and again affects the whole family unit. So it's something that, has to be addressed right away. And then, interestingly, also quote unquote good things, things that should be productive, like exercise or cleaning your house. This can also kind of get into a pattern where you can't tear yourself away. I've had people who, for example, they love painting and they'll get into the zone and they're painting and they literally cannot tear themselves away. They tell me, like, I know I need to go to sleep. I know I need to eat. I know I need to do this, but they can't tear themselves away. And this is, again, the strong, irresistible urge to participate in said behaviors. There is an inability to control yourself. In the back of your mind, your rational brain knows that it's wrong, but you still keep doing it. And then after participating, you feel this immense guilt. Like, why did I do that? That was so unlike me. And then obviously it can be harmful to not only individuals, but families as well. as you can imagine, if you are the wife of a Parkinson's patient struggling with this, and your husband has cheated on you, he had an affair, the heartbreak and devastation that can come along with that is immense. And so there can be significant consequences. Now, there are people that I would say are kind of at higher risk of developing ICDs and at lower risk. Technically, anybody is at risk with a high dose of dopamine agonist, anyone is at risk. But I would say the people that I am extra cautious about or watching extra closely are those who already have pre-existing propensities towards these behaviors. So, for example, somebody who already loves shopping, they're just a shopper, they tend to go on shopping sprees. You throw on even a low dose of dopamine agonist and it can really drive that because that pattern has already been established, that connection or that reward pathway is already there. Or similarly, I have people who I'm asking any impulsivity, any gambling issues, and they're like, well, I've gambled my whole life. That's like my source of fun. I go every 2 weeks to the casino. And so that can be challenging too, because teasing apart what is their baseline behavior that they've kind of always had for decades, versus, is something new or different with, starting a certain medication. Okay, so I talked about the old way to use levodopa, which was to delay it as long as possible. Because of the discovery, or not discovery, but because of how common impulse control disorders were becoming from people being on high doses of dopamine agonists, the new way of practice now is with the rational use of levodopa. And so the American Academy of Neurology, it's kind of the most prominent medical society or organization in the field of neurology. They put out a position statement in 2021. So this is very, very recent, only like 4 or 5 years ago. And they said, we carefully reviewed the available research on the effectiveness and possible risks of medications to treat motor symptoms in people with early PD and found that levodopa is usually the best first treatment for these symptoms. So when this came out, it was a big deal. It's kind of controversial. People are like, what? This is not how we've been practicing. But the reason that they did this is because, again, before people were on high doses of levodopa, they were getting dyskinesia, they were getting motor fluctuations. And based on the research that they did, they found that if you keep the doses overall low of levodopa, you can typically, again, nothing is zero risk, but you can typically mitigate someone's risk of developing motor fluctuations. And comparatively, using levodopa in someone's early Parkinson's versus using dopamine agonists, between the two, they found that levodopa is typically the best first option. So nowadays, we utilize levodopa a lot earlier and a lot sooner, and it is typically safe, again, using it in a rational way. Now, individualized care is still the top priority. So, again, I utilize dopamine agonists. There are some patients I will still reach for dopamine agonists first before levodopa, and that's based on their individual situation. So, an example of this would be if I have someone who, maybe they have early mild Parkinson's, but restless leg syndrome is really like their prominent feature, their most bothersome symptom that affects their quality of life, then absolutely I will still reach for a dopamine agonist first, because they tend to be a little bit better at treating RLS. But still, I'm really happy now that we have these guidelines, and I hope that that kind of illuminates rationale behind prescribing practices and also the history of why things have come to be the way they are. But again, dopamine agonists are not bad. They are utilized. There's absolutely utility for them. And if you, for example, have been prescribed dopamine agonists first, it is not anything bad. It's not, something that somebody did wrong. That's just how things have come to be, and everybody's different. Okay, so if you do develop impulse control disorders, what is the best management strategy? So the mainstay of treatment or gold standard of treatment is going to be reducing the medications, particularly dopamine agonists. Now, you have to discuss this with your healthcare provider and bring it up because I screen for it as much as I possibly can. But like I said, I have a long list of things that I have to get through. And for example, sometimes I'm spending 20 minutes out of our 30-minute visit talking about constipation, right? Or someone's mood issues or someone's sleep issues. And so sometimes, I can't screen for every single possible symptom or side effect. And so it is important that if you are noticing this in yourself or in your loved one, that you please, please bring it up. If I don't know about it, I can't help you. And so the options that we have, one, sometimes we reduce the meds and people do fine. They don't even notice. And that tells me that they were probably on too much to begin with. And also, it mitigates the impulsivity, but it still maintains some level. So the side effects are dose dependent. Oftentimes, lower doses of meds, you don't necessarily have to come off, but just lower dose of meds can reduce the impulsivity. Another option is switching to other medications. So let's say, for example, you're on a high dose of pramipexole. I can taper you down on it. We can gradually go up on another medicine like carbidopa, levodopa. This is not zero risk because if you recall from that slide of all the five D5, all the dopamine receptors, levodopa still has some receptor activity. And don't get me wrong, there are people who are on very, very high doses of levodopa and they still can develop this. So it's not zero risk, but it's definitely lower risk. And then utilizing other non-medication strategies to control your motor symptoms. So maybe we do go down on your dopamine agonist, but then you're struggling with more tremor or stiffness or slowness. There are many non-medication options as well. So one of the standards of our current practice is we utilize a lot of Botox injections to help with muscle rigidity, dystonia, and therefore tremors also can get better too. So um, in addition to that, there are also procedural options like deep brain stimulation. And so if that is of any interest to you, please bring it up to your healthcare provider to see if you are a candidate, because not everybody is a candidate for that. Another factor or thing that you can control at home is controlling the environment to reduce the impulses or the likelihood that you will give in to those impulses. So, for example, if you're someone who's been struggling with compulsive eating, limiting the snacks that you put in the house, if they're not there, then you're not going to eat them. Similarly, prohibiting going to the casino or prohibiting yourself from going to the store if shopping is a problem for you. I will say this has become increasingly difficult to do with online. It's so easy nowadays to just go on your phone, online shop, or even online gamble. It's become so common. So, as the care partner or family member, trying to put guards up on that type of, access can be important as well. And then lastly, psychotherapy, which is where cognitive care solutions can be really helpful. Um, I can't claim that psychotherapy gets rid of or can even treat impulse control disorders. I don't really have the data to say that. However, we talked about how this can become a very complicated family issue. There are different interpersonal relationships that can be affected, between husband and wife or father and child, obviously can become very complicated. There can be a lot of hurt feelings, feelings of betrayal. And so psychotherapy can really be helpful in addressing the family dynamics. And the other struggle that we see with impulse control disorders is a loss of insight. And I'll talk about this a little bit more, but if the person themselves does not recognize that this is a problem and therefore needs to be treated, then it's really hard. And so using the tools we have with our therapists to help the patient either understand the impact of their actions on themselves, but also understand the impact of their actions on their family members can be helpful in kind of getting us to a place of better insight. So, insight is an individual's ability to understand the nature or significance of their illness and that their symptoms need treatment. So, for example, if someone doesn't have insight, let's say they are shopping persistently, they can't stop shopping. But for them, they think, I don't have a problem. I've always been like this, and therefore I don't need to do anything about it. It's not hurting anybody, right? Maybe they're like, oh, I have the money, who cares? But it is a problem because at the end of the day, they are in this reward feedback loop that can extend not only to shopping, it can extend to other areas of their life as well. So it's important to put a lid on this side effect and this behavior. But I will say, these situations where the person is lacking insight can be very challenging. It's one of the most challenging situations that comes up in my practice because if the person has not bought into the fact that what they're experiencing is a problem or needs to be treated, then they're going to be resistant to treatment. For ICD specifically, the treatment is lowering their medication, and right, the medication is supposed to help you. Or maybe when they started their medication, they felt like things got a lot better. So the idea of pulling back on those meds can be challenging. And, it can be met with a lot of resistance, again, if insight is not there. So we see insight in other disease states as well, psychosis, Alzheimer's, dementia, bipolar disorder, schizophrenia. There are a lot of disease states where, unfortunately, the person does not lack insight, and it introduces a very specific challenge. So, in summary, dopamine is a big part of the story, but not all of it. There are other neurotransmitters that are related to Parkinson's. Managing Parkinson's involves not only managing people's motor symptoms, but also their non-motor symptoms, medication side effects, and also what's going on in the home, their personal and family dynamics. Screening for behavioral changes is key. Early intervention is the best. So if somebody is on a low to moderate dose of a dopamine agonist, they're having a little bit of impulsivity, like maybe they're becoming just a little bit more snacky than they used to, or maybe they're more likely to buy that thing that they wouldn't typically have. That's really the best time to intervene because at that point, the behavior hasn't caused such significant destruction. They still kind of have a lid on it, and they would likely respond really well to de-escalating the dose. Versus if you have someone who's basically in crisis mode, those situations are much harder to address. So early intervention is key. Again, please communicate with your healthcare provider. Like I said, I try my best. I try to screen people as much as I can, but sometimes time just gets away from us. And so communicate, communicate, communicate. There are things that can be done. We are here to help you. That is our job. And so if we don't know about it, then we don't know how to help. And then lastly, kind of building your social circle or your support circle to set you up for success. So reaching out to family and friends, support groups, if that's something that you think would be beneficial for you. Some people are not support group people, and that's okay. And of course, your healthcare team. Managing Parkinson's can be hard because Parkinson's touches so many different parts of your life, your family life. It can be challenging, but having a good team behind you, and that includes not only your healthcare team, but a personal team, your social support, is really key. And absolutely, I think sets people up for a long, happy, fulfilling life. All right, that is the end.